Artificial intelligence is transforming healthcare operations by helping organizations improve efficiency, automate routine tasks, and return valuable time to caregivers. Joining us today to discuss his organization's AI journey in healthcare supply chain operations is Dr. Dustin McLemore, who's a senior program manager with Providence. I'm Shannon Hale, senior PI program director with Vizient's PI programs team, and your host for today's podcast. Dr. McLemore, welcome.
Thank you, Shannon. It's very nice to be here.
Looking forward to the conversation. I find this topic fascinating. Many organizations, we see this daily, are still exploring where AI can help create meaningful value, specifically in supply chain operations. What opportunity did your organization identify, and how did you begin applying artificial intelligence or AI to address that issue?
There are a couple of things the use case for AI has taught us. We're never done identifying opportunities, so to speak. Any way that we can ease our way for our caregivers, that's incredibly important. But we've identified a couple of different instances where the use of generative AI and vision AI kind of combined into one solution delivery can really make a difference. In our urgent care settings is where it really started. But if you would for a moment, put yourself in the mind of a clinician in an urgent care. You are someone who is responsible for rooming and responding to patient needs. And you may see, depending on the urgent care, 100 or more patients in a given day. You also don't typically have a dedicated supply chain caregiver or representative on site with you. So if you're the medical assistant, you're the nursing supervisor, you're responsible for maintaining the life cycle of all of the supply chain needs in that clinic while seeing those patients, running a schedule, all of those different things. What we really decided was looking for ways to give our caregivers that are on the front lines back the time they need, promote cost containment and stewardship, and align ourselves with things like our supply formularies, which blend the clinical best practice along with cost stewardship and item availability. There are a lot of other instances where we're using AI in the supply chain space, specifically with ERP integration and invoicing. There's tons of opportunities, but the supply program is probably one of the most promising practices.
When you started this work, there was no commercial solution out there that really met your needs. What gave you and the team at Providence the confidence to build something from scratch instead of just waiting for the market to catch up and push something out?
We were in a unique position as a frontline healthcare organization to identify a need. We had to look at what the problem was that we were actually trying to solve. We needed a solution that eliminates manual inventory, formulary lookup, ordering tasks that historically consumed significant amounts of time, providing real-time visibility on formulary alignment and automation of requisitions, reducing stockouts. We were in the best position knowing the problem we had to solve. We have a very strong partnership with Microsoft. They were in a really good position to be able to collaborate with us on this piece. Why we had to actually build the solution from scratch rather than using a product that already existed was because when we started this journey a few years ago, there wasn't really a promising practice that had developed variation. We required that tight integration within internal formularies, our business purchase agreements, and requisition workflows to ensure compliance and really reduce that product variation. We also really need to solve real clinic level complexity, everything from inventory variability to ordering inefficiencies and workflow fragmentations that were really not addressed by any external tools. And we needed something that we ultimately were able to prove through a phased rollout and scaling across clinic with expansion waves, onboarding readiness, and platform maturity to be tracked as part of an active deployment strategy. We have a very strong partnership with our internal technology team, along with our healthcare operations and frontline clinical partners within supply chain. Those pieces together put us in that position to be able to solve the problem ourselves. There are some products and tools that are starting to come on the market, but that level of customization that we were talking about, that's still something that's developing.
You and I spoke recently, and one thing that really stayed front of mind for me was you described your tool as built, and I'm quoting here, by caregivers for caregivers. What did that look like in practice? And I'm interested to know who was at the table and how did that feedback really influence what was ultimately built?
The solution has to conform to the caregiver need rather than the caregiver having to conform to the solution constraints. When we started this journey several years ago, we initially experimented with a technology that had so many different system constraints that it actually added more time onto the workflow than the problem was actually trying to solve. So it was actually the reverse of what we really wanted. We brought frontline caregivers from clinics in the Puget Sound area in the urgent care space. We brought our healthcare intelligence team together, who has a talented team of developers, data scientists, and engineers. We also brought in supply chain experts, all together in a room at our campus headquarters in Renton, Washington, and started whiteboarding what were the problems, what were the intended needs from the caregiver's perspective. Take us through the pain points. My background, I started in a clinic many years ago myself and then spent several years in the OR before coming to Providence to do this work. That context for me was important. When we talk about this idea of built by caregivers for caregivers, we're designing a solution to reduce repetitive administrative steps and return time back to patient care with measured labor savings validated through caregiver feedback. This has been a pilot, so it's worked to a certain extent in some cases. And in some cases, we've also seen some opportunity where we've had to retool some things or maybe pause a clinic's participation just because it wasn't right for them in that moment. Our healthcare intelligence team, our supply chain program management team, and operations team have actually built dashboards and reporting solutions that actually show us the health of the clinics that are participating. We always have a clinician looking at the data that's coming in and coming out. We have clinical value analysis teams that are participating with us. We have a clinical RN that's handling clinical review of the decisions that the AI is making in terms of product matching. There's some really exciting research in this field, especially some things that are coming out of LSU down in Baton Rouge right now. This idea of human AI teaming research, and it emphasizes this augmented human decision-making, aligning to a model where caregivers can remain in control while AI reduces both the cognitive and administrative overload. And so research in industrial engineering is showing us a way that this partnership can both value add and advances in technology.
Those that are going to be working with this tool, they're at the front line. It sounds like they were involved from the beginning. And I'm sure as you continue to tweak certain things, they're still there at the table, right?
We have continuing ongoing town halls with them, especially with new clinics that come on board. We have a very talented supply chain program manager who has a background in inventory control and operations within the hospital that's actually shepherding the implementation of these solutions. She and our healthcare intelligence team leaders meet with those clinics, especially the new ones, once a week to talk about the pain points, to talk about the things that are going well. They held quarterly town halls with all of the clinics that want to participate. There's continual mechanisms for feedback there at the table, continuing to help us redefine that solution. We're taking our cue from research that's emerging in some of those instances that we talked about to better improve the services as well.
That's great. I recently spoke to another member who they had implemented a new policy and it wasn't necessarily being used as it was supposed to. So they went to the front line, to the people that were working and doing that work that this policy was for. And they got some great insights. What is the resistance here? What's the problem? You can get a lot of information by going to that front line because they're the ones using that tool. I'm going to read one thing here that I found fascinating. It's your data shows impact in two ways that I see that many organizations are struggling with. Over $500,000 in financial impact and 3.5 FTEs or full-time employees returned to patient care across 18 clinics in 15 months. That's phenomenal work. How did you build the ROI case and what convinced your leadership to continue investing in this?
Well, it's a couple of things. When we talk about that financial value, we're talking about a combination of both supply expense reduction and labor savings. In some cases, labor savings was experienced more deeply in other places. There were some places that actually even reported, hey, we're spending more time than this on this than we want to. But with all of that said, ROI tied directly to both quantified labor and supply savings. One of the main reasons was that we were able to combine that with other things that were already happening to reduce supply spend, knowing when things were happening, reducing the amount of times that the clinics have to order or have to conduct physical inventory. We tried to sustain the work through ongoing visibility into supply spend, those standardized workflows, and operational performance tracking via some of those business intelligence and decision support types of tools that our healthcare intelligence team has built. The research that we've talked about before reminds us that decision-focused optimization and AI analytics supported through measurable ROI will show that ROI through improved efficiency, resource allocation, and system-wide performance gains. When we talk about that FTE total that you mentioned, that includes clinical time back to patient care, but also less time that our supply chain support teams, our ambulatory operations managers, folks who are managing requisition life cycles, that's time that they're actually able to return back to overall clinic support and making sure that we're easing the way for our caregivers as well.
It's a win-win. Great work. Great results that you've got there so far. You made a clear point that AI should be a partner and not a replacement, keeping that human in the loop as a non-negotiable. Where do you see organizations getting that balance wrong most often?
Something that a lot of organizations, including ours, are still trying to find the balance of. The research has said that explainable AI and human interaction research shows that trust requires transparency, interoperability, and sustained human control. One of the ways organizations tend to get that wrong is over automating without preserving that human validation and operational oversight. So letting something go completely without appropriate stewardship. That's been a journey for a lot of organizations. Organizations may be quick at introducing solutions that increase complexity or mismatch real clinical workflows, driving a certain amount of change fatigue. We have to be very judicious and we have to be stewards of what we introduce, when we introduce, with that clinician focus in mind. Organizations sometimes scale automation before establishing clear governance, validation rules, and operating norms. Part of our journey has been knowing we have a very exciting organization who's focused on continual quality improvement and continual change, but we want to reduce or avoid change burnout or fatigue, achieving the reverse of actually what we hope to achieve, which is adding more time on and things like that. When organizations keep those things in mind, that human validation, operational oversight, governance, validation rules, and operating norms, and actually scaling the solution in the clinics or in the hospitals where the problem is happening rather than just in a lab or in a room will be the things that need to make the organizational stewardship better.
We see this a lot in organizations. I'll get an alert. Unfortunately, we get alert fatigue and we may override those alerts. So your tool learns clinic usage patterns well enough to make proactive stocking recommendations. And I'm thinking they're busy seasons, so respiratory syncytial virus, RSV, flu season. How are those recommendations governed so that caregivers trust them instead of overriding?
The system, just like any new technology, is still learning. It's very understandable that when clinics have a lot of things going on, when they have that volume of patients, especially in an urgent care, where there's both increased traffic and complexity of conditions happening, it's natural for people to fall back into this what works type of approach. The way that we can avoid that is, number one, by ensuring that we get continuous and real feedback that's based on data that's both valid and reliable. Number two, keeping them in the loop through those regular communication points that we talk about. And number three, on the back end, us as, technicians, engineers, and data scientists watching what's happening with everything from the requisition lifecycle to key performance indicators. So we're tracking how often are items dropped from requisitions that they don't need? How often does the system make incorrect recommendations on things like units of measure, which is, as our data engineering senior manager says, is the most complicated factor in supply chain data, unit of measure. We also are monitoring how often requisitions fail in the life cycle. And if we can monitor that at an enterprise level, then we can reduce the amount of times that caregivers are going to revert back. We're on a journey right now. The system is still collecting data to be able to make those intelligent recommendations on stocking levels and min-maxes. But the goal of the solution is for, if I'm a clinician and I'm headed into respiratory season, I know that the system is going to be able to say, I need more N95 masks, or I need more face shields, or I need more of this particular type of glove, or whatever the case may be. That journey is still in development. But if the data is actually based on real world conditions, then I think that's when the caregivers will actually trust the data.
The data piece is so important in any of the projects really that we hear about. If I'm a healthcare leader from a peer organization and I'm interested in trialing something similar in my organization, what would be the top, let's say 2-3 tips that you would give that leader starting off on this journey?
AI systems and their programs, they emphasize combining technical AI capability with systems integration and AI human design. These are all critical factors for successful adoption in healthcare operations. And if we look at what that means contextually, we say start with a phased rollout and real clinic pilots before scaling broadly across the system. We started in a very small setting, in a very specific track. The urgent care kind of combines that acute volume and complexity with the patterns that you might see in primary specialty care. Align tightly to your formulary. If you have a supply formulary, and we do in the ambulatory space especially, align tightly to that formulary sourcing and operational workflows to reduce variation and drive adoption. That stewardship that we were talking about is incredibly important. Invest in operational readiness. Very intentional about the devices you select, how you onboard the clinics, how you configure the data, and how you develop governance. Getting a clinic ready for success and actually engaging with them both during, before, and after the implementation are incredibly important. Do all of that really to avoid potential issues with scaling and be intentional. There was a point where we were onboarding too many clinics at once, and we had to pause that, take some time to let the system develop and let the caregivers get used to operating within that technology. Listen to your caregivers, not just to what the data says or what you as a supply chain leader think is happening, but the solution will live or die by the adoption that the caregivers themselves have with this. And if it's adding more time than it's supposed to, or increasing complexity, or not seeing the cost savings that it needs to, then that adoption will dwindle very quickly.
Those are some great tips. Thank you for sharing those, and thank you for joining us today.
Absolutely. Glad to be here.
Dr. McLemore, thank you for joining us today and speaking about your work with artificial intelligence to improve supply chain operations. And thanks to you, our listeners. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com.